Evening, everyone, and thank you for joining us for our webinar. And today we are going to talk about, I think, one of the most important topics lately as we start to plan families slightly at the later stage. So what exactly is happening and how the fertility looks like after 40 and what is the pathway? And I think the idea is of this webinar to be brutally honest and tell you exactly what can work, what can help you to achieve pregnancy, and what are the approaches, medications, monitoring, and how to personalize the treatment to your specific needs, your clinical history, and to your circumstances as well. And we are also different, and I truly believe that our bodies really perform individually. And this is what exactly we are going to discuss. So what can help us to achieve pregnancy at age of 40 plus. Tonight, I have a fantastic team from Plan Your Baby to run this webinar, and I truly hope you are going to enjoy it. We we got slightly oversubscribed as usually for this webinar, and I'm really happy to see that we will have so many attendees because it just proves how many of us are in this situation. I will encourage you to use our chat to ask us questions. Please tell me your name, where you're dialing from, your question as well. And at the end of the webinar, we'll have a Q&A session. And Dr. Sami and Dr. Nora and our senior nurse Vivi will answer your questions. And also we'll discuss some case studies as well. So yes, so tonight we are going to be a small team from Plan Your Baby, Dr. Sami, Dr. Nora, and Vivi, our senior nurse. And Dr. Sami, if you want to go to the next slide. Okay, so I'm incredibly lucky to be surrounded by the fantastic doctors with a huge number of years of experience. And both Dr. Nora and Dr. Sami worked for NHS settings and private hospitals. And they have seen thousands and thousands of cases in different circumstances, different diagnoses. And I think the niche, what we are going to talk about, fertility after 40, is exactly their specialization. So Dr. Sami, the floor is yours.
Thank you very much, Maria, for that introduction. And welcome to everyone who's joined us tonight. Hopefully you'll find it useful. And quite often we get lots of questions in these webinars, so I'd encourage you to start typing up early because, yeah, we often don't have enough time to go through them all, unfortunately. So, yeah, if you have a question that you're dying to ask, please start typing it soon. Okay, so tonight's webinar is kind of focusing on the older group of women that we treat in IVF clinics, women who are 40 or older. And there is a change that happens as a woman gets older. So one of the main things, as you can see from this chart on the right, is the rate of abnormal eggs. And when we mean abnormal eggs, it's mostly the genetics, the chromosomes of the egg that start to go bad. And if the egg has abnormal chromosomes, then that's going to reflect in the embryo. And then we end up with abnormal embryos. And then when we use abnormal embryos, unfortunately, the chance of pregnancy is very low and the chance of miscarriage is very high. And this is what makes it more challenging as a woman gets older for her to get pregnant and to have successful pregnancy as well. So for younger women, the cumulative live birth rate for up to 4 cycles is about 70%. But if you look at the older age groups, again, it depends on the age, but once you go beyond 40, it drops quite significantly, up to 40%, but it could be as low as 7%. You know, as a woman gets to 44, 45, then a very small proportion only of her eggs, 10% or less are going to be healthy. And that is a really restricting thing to have because then it means it's very difficult to get pregnant, not just with IVF, but even naturally. And miscarriage rates can go up as well for this exact same reason. So miscarriage rates are about up to 50%. Again, for older women, 45, 46, it will be higher than this. And if someone is just about 40, it will probably be lower. But yes, high miscarriage rates, low pregnancy rates, most of that is to do with the abnormality of the eggs in terms of chromosomes, and that is something, unfortunately, that you cannot change. It's just biology. So yeah, the things that change, mostly it is the quality that we said before. This is the biggest factor by far, and this is what's going to affect more than anything the chance of getting pregnant and for keeping pregnancy. Chromosome errors, we call them aneuploidy. And there's a way that we can test with IVF. So if someone is suitable for this, we can actually check the chromosomes of the embryos before we put them back in. Quantity of eggs also goes down as a woman gets older, starts probably reducing from the age of 35, but then even more rapid decline after the age of 40, especially after 42. So we tend to get fewer eggs, fewer embryos as a woman gets older. That can also introduce more challenges. Sometimes even the egg reserve can be so low that we find it really a struggle to get even 1 or 2 eggs for some people. But some other women after 40, they still have plenty of eggs, but still this problem of quality is there. Now, what's interesting is the receptivity of the uterus actually doesn't change. So even women who are 40, mid-40s, they still have good chance of getting pregnant if the embryo is genetically healthy. And we know this from tested embryos, and we know this from using donor eggs as well. So the uterus doesn't really age in the same way that the ovaries or the eggs will. And hormonal shifts, usually this is reflecting also the egg quantity or the egg reserve. So FSH will go up, estrogen can also go up. AMH, which is the other parameter that we check, will go down, and follicle count. And in this age group, it's even more important to have a very tailored protocol and to monitor closely, because there are more risk of things like premature ovulation, immature eggs. These are all things that somewhat can be influenced by protocol. Not everything you can fix, but at least the best that you can, you want to do. So what we measure when we start assessing patients, AMH, which is a blood test for egg reserve, something which it's sometimes focused on too much, because on its own, I don't think it gives you the complete picture. So we also will check antral follicle count, which is the number of small follicles in the ovaries, resting follicles, you could call them, that we can see on the ultrasound scan. And also a blood test on day 1, 2, or 3 to check hormones like FSH, LH, estradiol, to help us understand how the pituitary gland is working. Because if the pituitary gland needs to put out a lot of FSH, for example, then this is a sign again that the ovaries are weaker, less responsive. We're also interested in other hormones, so thyroid hormone, prolactin, blood sugar. These can all affect a woman's chance for getting pregnant and keeping pregnancy, and also it can affect the hormones and the responsiveness of the ovary. So that's worth checking too. We'll do an ultrasound scan to check the uterus, make sure that's all in good shape. And of course, we have to check the man. So we have to check the sperm and see if there's any problem with the sperm, because actually it's not that uncommon that there could be issues with his sperm that we need to be aware of. And if it's very severe problems, then it may also encourage us to do further investigations or think about treatments for the man if suitable. So what options are there for treatment? Well, of course, you can always try naturally, but if that's not working out, within 6 months, normally we say to start looking into investigations if you're 40 or above, and start thinking about treatment, perhaps, especially if there's an issue found. Sometimes it's quite simple. So if there is an issue with ovulation, if someone's not getting regular cycles and it still has a good reserve, sperm is okay, there's no issue with structure or worry about tubes, then we can try ovulation induction or assistance with conception, where we give tablets to stimulate the ovaries. Can do IVF. This is a common treatment pathway, and I mentioned earlier that we can also test the embryos, which can then reduce the transfer of abnormal embryos and reduce the risk of miscarriage. Some women may choose or may have the only option as egg donation if they are menopausal or perimenopausal. It may not be suitable to do IVF or fertility treatments with their own eggs. So we may consider egg donation if that is what they want to do. Of course, it's a personal thing. Not every couple would accept this, but this is an option that is now available. And yes, genetic testing on the embryo for aneuploidy, which is the abnormal number in the chromosomes, or for single gene disorders, PGTM, checking for genetic disease. This is something else that we can do as well. So men also have a decline in fertility, not quite the same as women. It starts probably around 40, 45 years. Most studies say it starts from 45. Quality and quantity of sperm will reduce, risk of miscarriage will reduce. The man may start to experience sexual dysfunction, so reduction in his libido, erectile dysfunction, and there may be other health conditions, which mean he has high blood pressure or taking medication for certain medical issues that can also influence the sperm. And there is an association as the man gets older, the older he is, about 45, that there could be an increased risk in miscarriages as well. But it's not like the women. So women, once you get beyond 40, it's a very rapid decline. Men can still stay fertile into their 60s, even 70s. They can still be able to even conceive naturally. Of course, that's not an option for women of that age. So first option for treatment we mentioned was the assistance with conception, or ovulation induction is the other term that's used. And this is where we will monitor very closely a cycle with stimulation in the form of tablets called letrozole. So we do a blood test and scan just at the start before we begin any medication. Then usually it's 5 days of the letrozole to try and stimulate the ovaries. We do another blood test and scan to see how she responded. And then we ask her to check for ovulation. Once the ovulation is confirmed on the ovulation stick, we want to make sure it's a true ovulation by doing a blood test. And quite often I would give a trigger injection to help release the egg. 5 days later, we do a progesterone blood test. And if the progesterone blood test is showing ovulation, then we will give progesterone support in the form of pessaries, and then a pregnancy test will happen. And hopefully if she's pregnant, she'll continue with that. If she's not pregnant, then she could try it again. So it's a much easier step, cheaper, safer than IVF, but success rates are very low in general per cycle. So around 3 to 5% per cycle. It might be slightly higher if she's slightly lower and it's purely anovulation and there's no other factor. But in general, success rates are quite low. So then we come to IVF. IVF is a much bigger affair. It involves hormone injections, which are going to be taken by the patient themselves daily. There might be a couple of injections, in fact, not just one injection per day. And there will be a need for regular blood tests and scans. So we do every other day blood test and scan for about 10 to 16 days is the usual time that we would stimulate. And this monitoring that we do for blood tests and scans can be done local. So we can do it close to your home. You don't need to come to London except for egg collection if you're having egg collection, and then for embryo transfer if you're having embryo transfer, that cycle you'll do it. So that is the only time that we would do it in London. Otherwise, everything else you can do back home, even after the embryo transfer. We monitor progesterone, so we check progesterone levels because sometimes they can dip. And if they dip, we need to increase the progesterone support. We do blood tests every 2 or 3 days, which can be done locally. And if the progesterone dips, then we can increase the amount of progesterone that we're giving that woman. But the monitoring is very important because with monitoring, it makes us understand how the stimulation is going, what medications we need to give. We can adjust medications. We have different types of drug to help mature the eggs or to try and reduce the risk of premature ovulation. We can tailor the medication dose as well. We don't give too much because that can lead to overstimulation and the woman can become unwell with ovarian hyperstimulation. But also I don't want to give too little because too little means that the woman gets less eggs and embryos and that will limit her chance. So it's a fine balance to get it right. And therefore the monitoring with blood tests and ultrasound is really, really useful to help us tailor the treatment well. So yeah, this is the post-monitoring post-embryo transfer monitoring, where we will do blood tests every 2 or 3 days. And actually, this is something which very few clinics do, but I feel it's important, and it can help also reduce the chance of spotting before pregnancy tests. Some women, they do experience spotting, and very commonly that's due to insufficient progesterone being given post transfer, and we really hardly see it in when we monitor the patients and support them. It's something which is extremely rare. It's not the only reason, but it's one of the commonest reasons is with progesterone. That's very easy to prevent. Okay.
So when we come with IVF with donor eggs or sperm, I mean, it's not just the last solution, but it is evidence-based for many people for a good outcome. So again, you would have implications counseling, you would select the appropriate donor eggs or sperm from the donor, and these are prepped in advance. And then the cycle is planned, consent forms are done with infection screening. So you either have a stimulation cycle if we're anticipating to put sperm, with the egg collection day to fertilize your own eggs, or we can do an egg thaw where we prepare the womb lining, and use a partner's sperm, or we can do double donation. So it's all it's all possible, and it's very dynamic depending on the choice. But just to stick to this webinar, we're going to talk about you getting pregnant with your own with donor eggs, and birth rates still remain above 30% across all age groups. So for a woman that's 43, 44, 45, the chance of her getting pregnant with a live birth is higher using donor eggs than using their own eggs, 7-fold. And this is like the latest data and the HFEA. Thank you. Next slide, please. So after that, you know, when we get a positive pregnancy test, and we like to do pregnancy monitoring, and this is all with remote consultation. All the treatment is with remote consultation, except when you come in for the treatment part. But in pregnancy, you know, bloods and scans are done, and you're going to have results most of the time on the same day. The nurses are 24/7. We're available as well to support during this journey. So there's close monitoring, especially in the first trimester, and then, you know, we can follow up to 12 weeks, and then you can carry on your journey. But we would love to know your outcome. So keep us in the loop. So IVF after 40, what are different points than regular stem cell stimulation protocols can be tailored. So we know that at 40, the egg quality and quantity is less. So we try to adapt the stimulation, whether it's a dose or modified medications, how we combine them. And, you know, we can have different strategies. There's no one way. So each patient is unique on its own. And that's why it's really important that you have that initial consultation. And it's really important for us to get to know you really well and have that detailed discussion, because we want to personalize and tailor things to you. So not one person is the same as the other, and cycles can differ between people. Other things which Dr. Sami mentioned was the genetic testing because of the abnormal population. Genetics in women over 40. So again, testing could be offered for these women. Embryo banking. So we could say that, well, my egg number is low, but can I still use my own eggs? Absolutely. You can do multiple cycles to, you know, bank embryos, and some cycles, you know, women can bank 1 embryo or 2 embryos, but you need multiple ones. That still could be done, and we could still offer that as well. So as you see, it's not one size fits all. It's what means and what's important to you as well. And the last thing is to consider donor eggs. So we consider donor eggs depending on the outcome. So, and also of what we see with AMH, AFC, egg reserve, and a detailed discussion. So again, live birth rates around 50% per transfer, and is dependent on age because we're depending on the donor's age. So it's good to come in for a discussion with an open mind, depending on what you're looking for. But again, there's no right or wrong. We're here to support you and try to offer the best options. Next slide, please. So IVF with PGTA was postulated because of these abnormal genes, and, you know, testing can be offered to a certain cohort and try to minimize chromosomal conditions. It's just really important to understand that if we have a low number of eggs, then, you know, you could test and see if it's suitable or not, but it doesn't remove all the risk. It's not going to clear everything, but it can let you know what kind of embryos do you have. But we can't change biology, but we can always test for it. Next slide, please. So I just wanted to cover a couple of cases. So we have a 40-year-old lady, heterosexual couple, and they had secondary subfertility. They've been trying to conceive for 2.5 years, but she did have quite a journey. So she has regular periods. She has 1 natural baby, born naturally, conceived naturally. So total number of pregnancies were 7 pregnancies. 5 of them were miscarriages. 1 was an ectopic pregnancy where she had her tube removed and then she had her baby. And they discovered that, you know, she has antiphospholipid syndrome because of all these miscarriages. Investigations were done. And, you know, it's where the blood is more clotting, and it's an autoimmune condition. But you see, once it's identified, when we know that, then intervention will increase the live birth rate from 10% to 85%. So knowing is key to make a huge difference. So she's fit and healthy. Otherwise, male partner had good sperm, all parameters were normal, and her AMX was on the lower side, 6.1, but the quality is at 40, not as good. But even though it's not impossible to get pregnant, as you see, she's very fertile, getting pregnant on her own. And we did a tube check and her right tube was open. So she had one cycle of IVF, which was canceled. There was no response. Second cycle, she had 3 eggs and IVF was done. We did, frozen single embryo transfer, a frozen single embryo transfer, but she wasn't pregnant. So she opted for a third cycle and 8 eggs were retrieved this time. And this shows you that, sometimes our bodies respond in different ways. There's no right or wrong, but she tried again and she did a double embryo transfer at that point, and she had a clinical pregnancy, and that's ongoing. So hopefully she'll deliver soon. And there's still 2 blastocysts in storage, so she still has 2 more to try in the future. Next slide, please. The other case is a 41-year-old woman, and these are a heterosexual couple, and they've been trying to conceive for 3 years. She used to be on the contraceptive injection, so, it doesn't take fertility away like many people may think, but it may delay the resumption of periods. But she's never been pregnant, regular periods. She has multiple fibroids, but is otherwise healthy, no issues. His sperm was reasonably okay, a bit of reduction in morphology, but that doesn't matter. But her AMX and egg bank was on the lower side. So her AMX was 3, and her follicle count was low. She had multiple fibroids, but they weren't affecting her womb, and both her tubes were open. So she had her first cycle. We gave good stimulation. She got 2 mature eggs, a single embryo transfer, so 1 only embryo developed, and she has a positive pregnancy test. So you see, different women can have different egg reserves and different responses. The other one had a higher AMH that was 6 and had to have 3 cycles to get an outcome. But this woman had a lower egg reserve and by chance. So luck does have to do with it, So there is a big spectrum. Some can have much higher egg reserves, some can have lower. Luck does have come into play as well. So we have to be mindful of that. But it is a journey and we have to be patient sometimes. And it can be frustrating when things aren't working. But we're here to support. Next slide, please.
Thank you so much, Dr. Nora and Dr. Sami. And as always, you're bringing so much of information, and we have multiple questions. But just before we move to the Q&A session, I would like to add what exactly also works for the treatment. The settings of the clinics plays a huge difference. Now, it is important that clinic will be open 7 days a week. And the reason for that, you never know when your egg collection should take place. And sometimes by performing egg collection on the wrong day can actually result to less mature eggs, to premature ovulation. And therefore, it is important that clinic accommodates according to your treatment. So Plan Your Baby has not only 7-day week service, from very early hours to very late hours and working weekends, bank holidays, but also multiple locations to help you undergo the treatment with less stress, less commute. And we have now close to 500 locations actually. So we try to reduce the number of minutes you travel from your comfortable place, either it's work or home, and then your treatment can be performed in the most less stressful and more convenient way, rather than a one single clinic where you have to commute all the time. And I've seen so many patients that suffered from this so much, and it actually brings more anxiety and stress that you unfortunately will have to deal with. In terms of how it works, we operate on the same day result. So regardless of where you are, Edinburgh, Exeter, or Wales, we will do your blood test and we will receive all of the results the same day. And as Dr. Sami and Dr. Nora mentioned, during the stimulation, we perform blood tests every day or every other day. So we start with every other day, and then the closer you're getting to the trigger or egg collection point after trigger, we will monitor your blood test every day. Now, the reason for that, because the precision, we work on a high precision and we need to make sure we trigger you exactly on the day that your body needs to help us to retrieve more mature eggs, and hopefully that will bring us to a better outcome. Now, in terms of the medications and how the delivery works, we have a couriers, they bring all of the medications to your doorstep. And again, it's a 6-day service, so either working days or Saturday, depending on what's convenient for you, we can arrange the medication delivery. And you always will have dedicated nurses and doctor who will review your results, and you can speak to doctor during the treatment at Plan Your Baby, discussing not only how you're responding, but also to give you some reassurance and if everything is going according to the plan. And plan is always made after we perform the initial consultation first, and then very thorough investigations so the most important for us to understand that we know what is the best protocol for you. And as Dr. Nora mentioned, the protocols at Plan Your Baby always will be tailored precisely based on your needs rather than applying a standard, treatment plan. Dr. Sami, would you like to go to the next slide? Okay, yes, and the very important part of the treatment is costs. Now, Plan Your Baby is a private clinic, and we do offer treatment from non-invasive to IVF and pregnancy monitoring. And you can see that assistance with conception costs £1,294, and approximately you would spend about £100 on medications. And then IVF treatment is about between £8,500 to £10,000 if we have to perform the PGTA. That would be separately charged for the genetic tests, and the pregnancy monitoring, if you would like to have it separately from your treatment. If you're just finding out you're pregnant, you can come to us and we will monitor your pregnancy. If you do have treatment with us, IVF treatment, you don't need to pay a management fee for pregnancy monitoring. Okay, Dr. Sami, next slide. Okay, so we had a huge number of sign-ups, and we made a decision that we will open up some more availability for initial consultations, because we do believe that this topic is really not spoken that much. The treatment sometimes can be offered less personalized, and we would like you to help. Either you are on a journey to change the clinics, or you just would like to have a second opinion, or you're just starting your pathway now and you feel like Plan Your Baby is the clinic to help you. So we have opened up additional slots, and we have created a discount for you. So you can either grab your phone and scan the QR code or record the discount code. It will be valid for 2 days. And then who will decide to start the treatment, we kindly will offer a £500 discount on IVF treatment. And hopefully this will help to manage the costs as well. And in terms of the payment plans, so Plan Your Baby has payment plans as well, if you need any support from that side. So I can see we have many questions. Dr. Sami, I really hope we will be able to cover all of them. And I will perhaps need as well help from my colleagues, Vivi, and we have Catherine who will help answering as well questions in the chat. Yes, Dr. Sami, let's maybe begin. So the first question would be, do we help patients with azoospermia if it's blocked?
So azoospermia means that there is no sperm coming out in the ejaculate. And it's not a common thing for men, because usually, even if there's sperm factor, it's reduced number, reduced quality, but to have no sperm whatsoever, it's not uncommon. We see it in our fertility clinics, but in the general population, it's not that common, thankfully. But there's different reasons why there can be no sperm, and it could be hormonal, it could be genetic causes, but also sometimes it's blockage, as it sounds like in this case. Sometimes it's blockage because of vasectomy. So men who've undergone vasectomy, that will block the tube that comes from the testes or the vas deferens. They purposefully block it, and it's not easy to reverse. Sometimes they reverse it and it doesn't work, and there's still no sperm. Or it can be something like cystic fibrosis or trauma or other reasons. So if the cause of azoospermia is blocked vas deferens, then that's quite easy usually to overcome. Of course, we'll need to make sure that there's no other cause, so we'll check the hormones, and there should be other checks done to make sure that this is the only likely issue. And most of the time, there can be a small procedure done where sperm is extracted using a needle, either from the epididymis, which is the sac that stores the sperm on top of the testes, or from the testicle itself. Sometimes if that doesn't work, though, they may need to cut into the testicle and remove the sperm surgically as well. But in these cases, usually we get lots of sperm, and even from one operation or one procedure, we can get enough sperm for many cycles of treatment. So it's not too difficult usually to overcome this. It just needs usually one procedure, and then we can start doing treatments.
Thank you so much, Dr. Sami. Dr. Noor, maybe you can help with the next question. So what can it mean if AMH is good level, but antral follicle count doesn't seem to align with the AMH levels and it's lower?
So AMH and AFC can have discrepancies sometimes. It could be a spurious result that we can repeat, or sometimes it's common with endometriosis, but in endometriosis, we can find a slightly lower AMH than the AFC. So it's very important to check also if there is any inflammation, any medical condition that can cause this discrepancy as well. It depends. The response to stimulation could go either way. Usually for younger women, if they have any medical condition, or when we do fertility preservation for cancer, they respond more with the follicle counts than the AMHs. But again, each person is unique. So unless we stim, it's difficult to know which way you're going. But we do monitor to have an idea.
Thank you so much, Dr. Nora. And Dr. Sami, in what situation would or wouldn't you recommend or consider PGT-A testing for women over 40? And maybe also some statistics would be great to hear.
So yes, I mean, PGT-A, at least in this country, is not a routine practice. In some places in the US, for example, it's almost standard now. And in some parts of the Middle East, UAE, some clinics, they also do it as standard as well. But in Europe and the UK, no, we don't offer it as standard, because there are pros and cons to PGT-A. And the biggest advantage, in my view, with PGT-A is that we can reduce miscarriage rate, because the commonest cause by far for miscarriage, first trimester miscarriage, is a genetic problem with the embryo chromosome abnormality. And if we're testing the embryos, we are able to assess this with about 98% accuracy. It's not 100%, but 98% is pretty good. And therefore, we can exclude embryos which may have genetic abnormalities that can cause miscarriage, embryos that have things like Down syndrome, Edwards, Turner's, all of these, which are to do with the number of chromosomes. We can fairly accurately assess now and remove these embryos. We don't transfer them, and that can reduce the miscarriage rate, first trimester miscarriage rate, which is great. The other advantage is it may reduce the number of transfers. So sometimes even for women over the age of 40, they have a very good egg reserve and they can produce lots of embryos. And I've seen women 41, 42, and they're producing 8 embryos plus cyst, day 5, day 6 embryos, 10, sometimes even numbers which are really huge. And of course, we're not going to transfer all of these embryos in one go. This woman will then have to go through multiple transfers. And what we see in terms of statistics for women who are about 40 years old, it's about 30% of the embryos which are genetically healthy, 70% are abnormal. If you get to 42, it's around 80%. which are abnormal, 20% which are healthy, 44 drops quite a lot, so it's about 8% which are genetically healthy, 46 probably around 1% only. So you can see how it drops quite quickly as a woman goes beyond the age of 40, and under 35 it's 70% healthy, only 30% are abnormal. So if we have the situation where women produce lots of embryos, then at least we can filter out those embryos that we don't want to transfer. It's not worth freezing and keeping these embryos. We can get rid of them, and maybe perhaps from the 8 embryos she only has 1 or 2 that are good, and then at least we can get rid of the other ones, focus on these ones. It reduces the number of transfers she has to go through, the heartache, the time, because also time is not on her side. She doesn't want to be spending 6-9 months going through many embryo transfers, and also, like I mentioned before, miscarriage as well. Now, disadvantages, yes, there are disadvantages to doing PGTA. First of all, not all embryos make it to blastocyst. Not all embryos make it to day 5 or 6, which is when we can actually biopsy, where we can take the sample of cells and check the genetics of the embryo. Some embryos will make it to day 3, and then they don't do so well after that. And therefore, if we only have 1 embryo, it may not be worth doing the PGTA. It might be worth just putting the embryo in, hoping and crossing our fingers that this is a healthy embryo, and then she may be successful. Also, doing the biopsy means you have to freeze. So when we take cells out, it takes 2 or 3 weeks to get the results of the genetics. And therefore, we have to freeze these embryos. And freezing the embryos, biopsying embryos, thawing the embryos, each of these steps can slightly stress the embryo. So it might slightly reduce the pregnancy potential, significantly reduce the miscarriage rate, but slightly reduce the pregnancy potential. Again, if you only get 1 embryo, I don't really usually think it's worthwhile unless the patient is very keen. And it has a cost as well. So, doing the genetic test, you have to pay extra for this. Sometimes it's 2,000, 2,500, 3,000 pounds extra you'll pay, depending on how many embryos you have to test. So yeah, it's not an insignificant cost. So this, and you have to go through 2 steps, because you have to freeze the embryo, you have to go through fresh stimulation and then frozen stimulation. So in general, the best person to do the PGTA, in my opinion, is if they are older, 38 or above, and they have good egg reserve. Or sometimes we see people who've had recurrent miscarriage, especially when we know it's a chromosome issue. Then again, yeah, PGTA is very good for those people.
Thank you so much, Dr. Sami. And to be honest, the tendency is there, and I do see more and more patients choosing to have PGTA just with a view to reduce the risk of lost time. God forbid it's miscarriage, and then it takes time to recover. And sometimes, if it takes 6 months, the time is irreversible, and it can result to no baby at all. But again, this treatment is not for everyone, and it just has to be discussed with doctor before you make a decision. Another very interesting question. Actually, I've seen cases like this myself many times, and it will be very interesting, Dr. Sami, to hear, and Dr. Nora, what do you think? So what would you recommend for patients who experience dominant follicle during the stimulation, which then reduce the ability of smaller follicles to catch up in time for egg collection? So this seems to have got worse for me since approaching 40 versus my cycle at age of 37. And would you recommend treating endometriosis before any transfers? So she's struggling to decide how many embryos as well to try and test and bank at nearly 40 before getting endosurgery.
Okay. So with regards to the dominant follicle, it's very important to differentiate if it's actually a dominant follicle or a functional cyst. If it's a persistent functional cyst, then we either wait for it, try to give progesterones, or we drain it first, because functional cyst means that it's producing estrogen, and that can affect the stimulation, and the response might not be very well. So sometimes we have to drain it before starting stimulation a few days later. So that's one option to make sure of. The other question was about endometriosis. So with regards to endometriosis, it depends where it's affecting. If it's affecting the ovaries, and I'm sure that when they come for surgery, they want to remove everything as possible. So it's better to do the IVF first, or at least freeze all embryos, and then go ahead for their surgery. So that's my suggestion.
Yeah, one thing I notice a lot of patients, they will have a scan as they start the treatment.
Yeah.
And on the scan, they'll tell them, oh, you have 5 follicles on the right ovary, you have 5 follicles on the left. And they then take away that information and think that that means they're going to get 10 eggs. But unfortunately, it doesn't always work like that. So you may have 10 follicles at the beginning, you may just get 1 egg. You may have 10 follicles at the beginning, you may get 18 eggs, because sometimes they're very small ones that then start to grow, which we see later on. We didn't see them at the beginning. So it depends on also how responsive the ovaries are to the stimulation drugs. And unfortunately, as you get older, there tends to be a reduction in the response of the ovaries to the medications. It's a natural thing that happens. And this is what this woman is mentioning. As she got older, the cycles showed more of a difference between the size of follicles. So, she's hoping her small follicles will grow and only some bigger ones were growing, is what I presume has happened to her. Now, yes, there are things that you can try and do. I mean, you can adjust the stimulation to maybe push a little bit harder at the beginning. Sometimes you can recruit more follicles that way. Doesn't always work, but it can be an option as long as the hormones are suitable for this. Sometimes I use drugs like letrozole or corticosteroids like dexamethasone. Sometimes that can also improve the ovarian response. But ultimately, there's only so much that we can do. And if the ovaries are weak in their response, then this is not an uncommon situation where we only get a few of the follicles to grow. And unless the follicle grows, and you're not likely to get a mature egg, unfortunately. And if you don't get a mature egg, it's not likely to be useful. So yes, there may be some eggs which we just can't make use of, unfortunately. This becomes more common as you get older. Definitely, I would echo what Dr. Nora said. If you're thinking of endometriosis surgery, then one of the risks of endometriosis surgery, especially if they start operating the ovaries, is the ovarian reserve can drop. And already if you're a bit older, or if your egg reserve's on the lower side, then it may be much more difficult to get eggs from you afterwards. So much better approach is to freeze eggs or freeze embryos first before going down the route of treating the endometriosis. And usually I wouldn't recommend going too crazy with treating endometriosis unless you're really struggling with symptoms. Your symptoms are very severe from endometriosis, pain usually, or other problems with bowel, etc. It's probably better not to fiddle around too much, because it doesn't have as much impact as you may think on the chance for conception. There are other things that we can do to treat the immunes and giving extra progesterone, etc., which probably going to have more of an impact than putting yourself through the surgery. So it's a bit of old-fashioned belief, in my opinion, from 30, 40 years ago when we first started doing laparoscopy, that anyone who's struggling fertility would have a laparoscopy, and any endometriosis would be removed that you could see. But when you actually do the laparoscopy, what you remove with the endometriosis is the tip of the iceberg. There's a lot of deep-seated endometriosis that you can't see and you can't reach, and it's not safe to get to. So you're not curing the endometriosis by going through surgery. It may relieve symptoms, especially when there is a lot of endometriosis in sensitive areas, or there's bands of adhesions. Then that might help the pain side of things, but it's not right to think that you can cure your endometriosis by going through an operation.
Thank you so much, Dr. Sami. And just quickly for me to ask, this dominant follicle, now by changing the stimulation dose every day and really adjusting according to the picture what's happening, because when we do close monitoring, we have much more information rather than when it's unmonitored. Can this help to synchronize follicles?
Yes, I mean, it can help synchronize. There's a limit to what it will do, of course. And usually, if there's a reasonable egg reserve, I will maybe put a higher dose at the beginning, first week, to see if we can recruit more follicles, because once they start to grow, then it's much easier. You don't need to push them so hard later on. Even with smaller doses, they will keep on growing. It doesn't always work though. There's no way that we can be sure that we're going to get all these little follicles to grow. It's impossible.
Thank you. And just heading to endometriosis and adenomyosis. So in terms of stimulation protocol, I know there is a lot of myths and approaches, but would a mild or natural protocol be better?
So, I think that we're talking about mild protocol for stimulation. No, there's no relation between the mild protocol and endometriosis. It's not, or adenomyosis, it's not linked. Natural protocol, I think they're talking about maybe frozen cycles. Yes, it can be an option, but it's not the only option. We don't get very high, or we don't give very high dose of estradiol when we're doing frozen cycles. So we only kind of try and mimic the physiological or natural range that a woman will have. So there isn't a protocol that I would follow just for an endometriosis patient. I think you have to look at the whole picture, not just endometriosis or not just adenomyosis. And actually, with these people, a lot of the problem is more to do with inflammation, and that is something important to cover because if a lot of these people, they actually get lots of eggs and lots of embryos and the top grade embryos, and maybe even we've tested the embryos and they're healthy, but they're still not getting pregnant because there's too much immune activity that has to be looked at, or even the microbiome. There's research that says that it can be different for patients with severe endometriosis. So these are things that also should be checked and maybe more important than the exact protocol that you use.
Thank you so much. And then just adding to this question, so someone who is 45 and have done 3 rounds of ICSI, and very good the ovarian reserve and between 10 to 22 eggs collected, the maturity and fertilization, but struggling to make quality blast cyst. So last cycle one euploid embryos in 3 rounds, and sadly this embryo did not implant. Now, going back to the mild and natural cycle, natural stimulated cycle, do you think for older patients, maybe 44 plus, does it make any difference, mild treatment, in terms of the quality of eggs we are producing?
Hardly not, no. And for this woman, I would definitely not recommend mild or natural cycle because she's producing so many eggs, way above average for her age, 10 to 22 eggs. And actually what she needs is to get more eggs because then there's more chance that maybe one of them will be good because already, as she's experienced, very few of the embryos are going to be genetically healthy, and the more eggs, more embryos you have, the more chance of finding a healthy one. So no, I wouldn't recommend in this situation a mild or natural cycle, but if someone at this age is a very low egg reserve, very poor response, then yes, that would be a good option.
Thank you so much, Dr. Sami. Now, going back to PGTA then, in terms of any drawbacks and disadvantages apart from the maybe risks of not having embryo, anything else, Dr. Sami, you could, or Dr. Nora, you could mention?
Nora?
So, I mean, there was a lot of talk about discarding normal embryos, but I understand that the technology has changed quite a bit. So, that's one of the things that you can say that the embryo is abnormal when it's actually normal. But that was when they were doing day 3 and day 4 biopsies. And from my understanding, things have changed quite a bit. The test accuracy is getting better. But the issue is we can't change biology. We can only test it. So that really needs, we need to manage expectations because sometimes people think that this is the magic thing to make a pregnancy stick. It doesn't. Even normal chromosome embryos can miscarry as well.
This is what really breaks my heart. I hope in the future technology will allow us to reduce those things. Another very important question, again, very perhaps related to age. So, Dr. Sami, Dr. Nora, with severe diminished ovarian reserve, apart from the protocol, anything extra, that can help to, support the cycle, maybe to help with producing multiple follicles and the quality, of course, the most important.
So with stimulation, we can only grow what is there. We can't create new eggs. We can't make eggs respond. We can't make ovaries respond. And when there is a really low ovarian reserve, even across all ages, follicles can misbehave. Okay. So even when they're a bit older, it's difficult. So apart from stimulation, there's no magic supplement that can create eggs, if that's probably what you're asking.
And can I just ask you, because I know we practice this at Plan Your Baby and sometimes we see a positive impact. So something new that is called PRP, the ovarian rejuvenation, and also maybe the growth hormone. So something that also can be prescribed for diminished ovarian reserve. So if you have any statistics maybe to share, that would be also great.
Dr.
Yeah,
Sami?
so these two things, they are controversial. So there are some studies that say they can help. There are some studies that say they don't help. And they are still under research. I think the situation is that there's not one thing that works for everyone. And in my own experience, I've felt that there have been many patients who benefited from taking growth hormone. I felt that there have been many patients who benefited from PRP as well. But there are also many I've seen who took these treatments and it didn't make a difference. So it's a situation where we kind of judge and see, has everything else been done that can be done? Are we really stuck here? Is the patient prepared to go for these treatments because they are quite expensive and they have other associated risks and problems? And then tell them that, look, this may help, it may not help. We can try it one cycle and see if it works for you, great. If it doesn't work, then we know at least it didn't work. Because probably only about 30–40% of people respond to these. But sometimes I do see patients, they're quite keen to try them. And, I do feel that for some people, they can actually make an impact.
Thank you, Dr. Sami. I think, as I said at the beginning, we're going to be brutally honest. And we are not here, to say that this is something that we don't believe and there is always going to be a success rate per treatment. There is no 100%, even for, paracetamol that can give you severe side effects and you can be that one unlucky. But I've seen myself cases at Plan Your Baby with diminished ovarian reserve after a few sessions of PRP. We retrieved cycle number 1, if I remember correctly, 2 eggs, but cycle number 2 after PRP sessions, 6 eggs, mature eggs. And that was, I think, an evidence that sometimes this small percent can make a difference. And even though the costs are associated and it may really not work, but if there is this small chance and it's explained to you, the risks, and if you're ready to take this chance, I think for some really it can be a solution. Especially, when the time is not as well on our side. Many of us may feel that we are ready to throw absolutely everything what we have, just because we anyway not gonna have, too much time or, many chances. Dr. Sami and Dr. Nora, about the statistics. So I know in the past we did not have a great statistics, but now in 2026, would you recommend fresh embryo versus fresh transfer? And what are the success rates if patient has to consider one or the other option?
Fresh versus frozen. So this is, a big debate. And again, if you're doing things like PGTA, so like in the US, for example, I have a colleague friend who works there, and she told me she hasn't done a fresh transfer for 7 years because everyone has genetic testing and therefore there's no option to do fresh transfer. But again, here in the UK and in Europe, fresh transfer is still commonplace. And yeah, I think in general, if you're not doing PGTA, if everything is good with your cycle, your lining is good, your hormones are good, you haven't got high progesterone. It's one thing that we check as well before trigger is the progesterone level, because if the progesterone is too high, there's a lot of evidence that says that your chance of implanting that embryo is going to be very low because there's not going to be good synchronization of the lining with the embryo's age. So if everything is good and lined up, then yeah, we should go for a fresh transfer. But if you need to do genetic testing, or sometimes the couple, they want to freeze, they're not ready for pregnancy, or there's some medical reason to freeze the embryo, then that's also not wrong. The actual difference in success rates between fresh and frozen nowadays is very little, because it used to be in the past there was a much bigger difference. We used to use a different technique, slow freeze technique. Now we use a vitrification, which is a fast freeze, and it's actually meant that the difference between freezing embryos and transferring them fresh is less. But ultimately, the best chance is with the fresh embryo, as long as everything else is ideal and optimal. If something is not right, then no. If we've seen something on the scan like a polyp, or maybe there's some fluid in the tube, hydrosalpinx, then no, we should freeze the embryos. There's no benefit then to just doing it fresh for the sake of it.
Yeah, and just if I can echo what you're saying. So when we do a fresh transfer, we're creating the embryos and transferring it right away in that cycle. So assuming everything is aligned and good, I mean, the pregnancy rate should be depending on the female age. When we're doing a frozen cycle, we're trying to grow the embryo. So there is some natural selection that happens with embryos that grow in the lab. So it's like, the drop-offs happen. So the best of the best is probably frozen. That can give more of a realistic chance of pregnancy. But again, it's it's still a debate. There's not one that's better than the other. Some less than 3% of people on all ages may not have anything to freeze as well. So that's just to be mindful.
Thank you so much, Dr. Nora. The next question, perhaps I will answer. So, how do you maintain, in terms of the stimulation, the quality during the stimulation of the ultrasound scans, because the scans are not performed by Dr. Sami or Dr. Nora? Now, we have a network of diagnostic centers we work with. They have fertility sonographers who are specialized in fertility scans. And Plan Your Baby has created a protocol how the ultrasound scans has to be performed during the stimulation cycle for us. So in 4 years' time, we didn't have even a single case, and touch the wood, that we were disappointed, or when patient went for egg collection procedure and we retrieved significantly less eggs due to the lower number of follicles for that reason. So that never happened. It's the other way around happened, that we actually retrieved more eggs than we thought. But in terms of the quality, we are absolutely, obsessed to ensure the ultrasound scans are performed exactly according to our protocols. And this is something that we have worked really hard on before we have built the network of all of the providers that we have right now. And now we have more than 150 ultrasound locations across the country.
I can also add, Maria, that we also, when we get the report from the sonographer, they also will have taken photographs, pictures, and also quite often videos, which I can then review, or Dr. Nora can review, and we can see ourselves then, the follicle measurements. We can check the ovaries. We get a good overview if there's a video, the lining, etc. We can see these things. So yes, we weren't there in person, but we still get images to look at.
Yes, that's a very fair point. So this is exactly what also limits any kind of discrepancy as well. Dr. Sami and Dr. Nora, I know we've run out of time, but just one last question, and then perhaps we will have to finish. So regarding the genetic testing, so the test that we do, for example, PGTA, can they rule out all the genetic abnormalities, including the Down syndrome, or there might be something that the test may not reveal, and eventually it will be identified during the pregnancy?
So what I understand is that they see the different chromosomes and their numbers, but they don't do genetic testing for genetic disease. We need to understand that difference. If there's chromosomal shuffling, that's not done either, meaning that the number of chromosomes is correct. However, there is some shuffling in the DNA that's abnormal, or that isn't done. But it's just to say, if there's an extra 21 chromosome, which is with Down, or a missing chromosome, such as in Turner's, that's what it tells you. That's the information for it, as far as I know.
Yeah, and it's a screening, so
it's not diagnosed.
Even though it's very accurate, 98%, there's still a very small chance there could be an error. So we still recommend for women who get pregnant to go through the normal screening process at 12 weeks. It's very rare, but it's still worth checking.
Yeah, absolutely. Well, thank you so much, Dr. Sami and Dr. Nora. Just from my side as well to add, yes, there is so much more that is outside of our control in terms of yes, we can check the genetics, we can do PGTA, and then the environment plays the role. Immunology as well is a big factor. And also what Plan Your Baby offers during the IVF treatment to support and improve the chances is the psychologist. So we have psychologists, and we include one session to each IVF cycle, and it's absolutely free of charge. And we also have the consultation with nutritionist. So we try to address the holistic side of it and try to help patients improve their chances through those approaches. I know we have not answered and covered all of the questions, but we will cover them. So please try to contact us. You have links to book a consultation as well. And if you would like to follow us on Instagram, please feel free. We're doing those webinars every 2 weeks, and we have more topics to discuss. I think there is so much more that we can help with, and and try to turn every single rock and answer on the questions. And Dr. Sami, Dr. Nora, it was absolutely a pleasure to have you again. And from my side, thank you so much for helping so many patients. We had absolutely incredible amount of patients joining tonight, and I really hope that the answers gave you some assurance and yes, and the expertise that those doctors have is just incredible. Thank you.
Thank you everyone for joining as well.